All right.
Sure.
Okay, so welcome everyone. This is Dr. Maleki Balak Maleki. I'm president of TOS, and we're excited to have our annual joint TOS and DOVS grand rounds. This year, again, it's a virtual rounds like it was last year. Hopefully, this will be our last virtual rounds. Hopefully, next year we'll be able to do this in person. Just to give you some housekeeping, just to update you on some housekeeping things. Obviously, our spring golf is canceled this year because of COVID. In terms of the fall gala, usually we have a fall gala every fall, and so right now it's on hold. We're just trying to figure out what to do with that gala. We may have to reschedule it for a slightly later date, but we'll keep you posted. The best way to keep in touch is to go on our website and go frequently, and we'll update you on what's happening for the TOS in the fall. And so I just want to give a thanks to the TOS Executive, which includes the past presidents, so Steve Arshinoff, Deepa, as well as our president-elect, Jonathan Shelley, and our treasurer, Natalie Payson, and our secretary, Kay Lam. The cycle of the TOS Executive changes every 2 years. So in the fall, we'll probably have an opening on the executive. So if anybody's interested in joining the TOS, feel free to send me an email or reach out to anyone on the executive. And in the fall, we'll probably add some new people in the group. So without further ado, I'm going to pass it on to Sharif El-Dafrawi. I just want to thank the UofT for helping to organize this event virtually, and I'll pass it along.
Great, thanks very much, Bebek, and welcome to everybody to these combined rounds. You know that the TOS has always done an excellent job of bringing community and academic ophthalmologists together in the GTA. It lets us exchange information, learn together, as well as see each other and socialize. And so, unfortunately, we're back to another virtual session, but I'm sure we'll get back to being together soon enough. It has been difficult with the pandemic, but we're all becoming experts at social media and virtual platforms. And so it's great to see these combined meetings continue to happen. I'd like to thank the TOS Executive for their work at maintaining these rounds. And I also want to say a heartfelt thank you to the TOS for supporting the surgical wet lab at UofT. The golf tournament has always provided support for that wet lab, which is a vital part of our trainee education. I wanted to take the opportunity just to thank a few people on the university side. There's 3 individuals who have worked very hard over the last year to ensure that all our teaching sessions, our rounds, our educational sessions continue and are accessible to everybody during the pandemic. And I think they've done a wonderful job of making sure everyone has access to them. There are, of course, John Lloyd, who's here on the panel. A big thank you. Alan Slomovic, who's done a terrific job at creating many more virtual sessions. And a very special thank you to Amandeep. And we've taken Amandeep away from his young family almost nightly now to run all our sessions, and he's done a magnificent job. So thanks to that crew. And so I'll turn it over to Steve and Manjul. We're looking forward to your talk. Thank you.
Okay, thank you, Sharif, and thank you, Babak. I'd like to share my screen because I thought if we're going to do this on Zoom, I might as well show a picture or something. So let me just put this up. Talk about our meeting, TOS. Hopefully you can see what I want to show you. So this evening we have the great pleasure of having our annual TOS UofT DOVS combined rounds, and our guest speaker is Manjul Shah. We put there the learning objectives, and I also want to thank all of the executive of the TOS who have been working for the last year or two to get this going. Poor Manjul, I think I've rescheduled him about 4 or 5 times. And every time I email him, I get an email back the same night saying, sure. So I guess his schedule has been affected by COVID as well. He's never that busy because he always says yes very quickly. So hopefully things will change for all of us. So let me tell you a bit about, here's our schedule for tonight. And Ike's going to talk a bit about Manjul after me. And this is Manjul. So Manjul is a clinical assistant professor at the Kellogg Eye Center in University of Michigan in Ann Arbor. he's an interesting guy because if you look at him, he has gone from university to university, getting his education all over North America. He's an engineer, bioengineering from University of Pennsylvania, a school that I actually also went to for a very short time. It's a great place. And then he went to Washington University in St. Louis for his MD, did his residency in Portland, Oregon at the KCI Institute, and did his fellowship with this guy named Ike Ahmed, who has trained many, many fantastic fellows. For a young guy, he already has 24 peer-reviewed publications, a book chapter, a book he recently wrote with Ike, and he's really very productive and had lots of great ideas. His interests are in MIGS, in IOL-related pathology, which we'll hear about tonight, complex cataracts and lens surgery, and management of iris and pupil pathology. Just want to tell you how I met this guy. So both of us were guest speakers at the 18th annual Down East Ophthalmology Symposium in Bar Harbor, Maine, just before the pandemic in September of 2019. And probably like some others, Ike and I and many others, we give lots of lectures. And when you go to these meetings, you give your own talk. And then, a lot of the talks, after you've done 1,000 or 1,500 yourself, they're kind of a little bit boring. But I think I gave the first talk that morning on bilateral cataract surgery. Then I sat down and this young guy got up. And within 3 seconds, I was just staring at the slides and listening to him, because this is the kind of talk and what he was talking about. You say, why didn't I ever think of that? Everything he says, you say, God, he's right. That's exactly how it is. And it was really an eye-opener to see this young guy get up there, and he's really thinking straight, and he has great ideas that can help us all in our surgery. So with that being said, that's kind of enough praise for the guy. And now we'll make him get out there and perform. So now we'll turn it over to you, Manjul, and we're looking forward to your talk. Thank you very much.
Well, Steve, before you do that, I got to say a few words, man. He's my former fellow.
Oh, sure. Go ahead, Ike. Yes, of course.
And I apologize. I'm just, it's our Eid date, so I've been doing drive-by visits with family. So I'm just driving around today. So I apologize. I'm a bit, I'm not dressed for the occasion, but most of you know already, I'm never dressed for the occasion. Manjul, it's a real pleasure to have you here as part of our UofT rounds. Your year here spent was an incredible year. Steve has really talked about how you've accelerated your career path. Those of you who may not know, Manjul has taken a very big role at one of the leading institutions in the world, at the Kellogg Eye Center at the University of Michigan. He is an integral part of the Glaucoma Fellowship and directs the fellowship. And speaking from the resident perspective, I know many of the residents that have come through University of Michigan, he's a favorite teacher, educator, and mentor. So Manjul has had a major impact already, just in only a few years. He just finished his fellowship back, it feels like only a couple years ago, but it was actually about 5-6 years ago. When you were a fellow, we could tell that you were destined to do great things. One thing that I really remember about you is your keen sense of observation. As an ophthalmologist, that's one of the things we always teach students about, the importance of subtleties and looking for small little details when we examine patients or take histories. And Manjul was an astute clinician, being able to pick up the faintest of small details that were critical to make a diagnosis or to put together a puzzle. And you'll hear us talk today is very much about putting together puzzles. That was very much Manjul, an ability to take this information and be able to put it together into a coherent and articulate, diagnosis. Of course, Manjul, he's a fantastic surgeon, and everybody really enjoyed having him here. But most of all, Manjul is really, he's, even though he's trained all over the place, he's American, he really bleeds Canadian blood. Okay, he bleeds Canadian red. And the reason I say that is because, and not with no disrespect to anywhere else in the world, he thinks very much as we do in Canada. He is a true humanitarian. He loves his fellow brother and sister. He looks after people before himself. He truly is looking for, helping those that are vulnerable, those that maybe are not as privileged as we are. He's a real role model. He impacted me in terms of how I think about people and how I think about life, because he's truly, at a very heartfelt level, a great human being and a physician for the right reason. And I'm not, no disrespect again to anyone else, but he really practices medicine to help people. He practices medicine to make a difference in people's lives so they feel more fulfilled. And he goes above and beyond the eye to make people feel relevant in society and feel productive. And that I feel very proud. I had a chance to be part of his journey in his fellowship and his education. And I'm so proud of where you've come, Manjul. So I'm excited to see you here. I won't razz you too much. I will be listening, of course, as always. And again, thank you for being part of this. And Steve, and TOS. Thank you for all the support you've done over the years, and thank you for allowing me to say a few words here. I apologize again. I'm not quite at my home office to share my thoughts. So thank you very much.
That's great, Ike. Nice hat.
Covers my hat head.
Okay, Manjul, it's all yours.
All right. Wow. I thank you all so much, Ike, Steve, and everyone else. Just a true honor to be with you, to connect with you, and just be part of this community. It's really been a privilege to be connected to all of you and spend a little time with you today. I have had the good fortune of training at a number of institutions and kind of bouncing all over the continent. And without a doubt, my year spent with you guys in Toronto was the inflection point in my career, and has really allowed me to broaden my horizon. So I really want to thank Ike, Steve, and the community that you all live in for creating an environment that encourages thinking outside the box, and really, again, focusing on the person and doing it for the right reasons. So today we're going to talk about fun challenges with intraocular lenses and the problems that they can cause. My disclosures are here. And again, I want to thank you all. Again, my fellowship year now, I thought it was just a few years ago too, but it's now it's about 6 years, was just one of the high points in my life. And we had a blast. We learned a lot. And again, I became introduced and connected to a community of ophthalmologists and astute clinicians, amazing surgeons, thinkers, and leaders through the Toronto community and beyond. And those connections, those gifts continue to bear fruit year on year. And I'd like to think that my residents and my fellows and my patients have benefited from all of you. So thank you. With that said, let's talk a little bit about lenses. So in terms of IOL surgery, we all do IOL surgery or take care of people who have IOL surgery. And so whether or not these specific techniques that we're going to go through are relevant to one's surgical practice, or these are patients that roll through our clinics, and we can really make some big changes in their lives. Lenses are fantastic and have evolved over several decades to provide incredible quality of life for patients, but there are definitely problems that can arise. We definitely are seeing an increasing number of patients who are developing IOL-related problems. That could be folks who had earlier generations of quote-unquote modern cataract surgery that may or may not have been as zonule friendly. The baby boomer population is starting to age, so sort of age-related zonular diseases and whatnot are continuing to progress. And so we're going to see these patients show up in any of our clinics and subspecialties. Certainly, these patients have come to my practice through cornea clinic, certainly my glaucoma clinic, the general eye clinic, the ocular inflammation clinic, the retina clinic, and we've actually have some come from the adult strabismus clinic, because patients may be complaining of monocular diplopia and be sent to the wrong provider. So an astute clinician has to be aware of this regardless of your subspecialty. So how do we approach this? Well, it's as my residents like to kind of note, it's very easy to kind of blow past the history when talking to eye disease patients, because we make so much of our diagnosis and our treatment plan based on our examination. The patient can say what they want. I'm going to look at the eye and come up with the plan. I could do this with, earplugs in. But really, with IOL related problems, history is incredibly important. And this is something I learned as a fellow from Ike. Subtleties of differences in visual phenomena and symptoms can really point to different locations for pathology, and can really help you localize your exam and technique. some symptoms such as the specific type of dysphotopsia or positive or negative changes, positional change in acuity. Certainly, we want to get a good clinical history of the surgical procedure, lens type, date, other comorbidities, as well as inciting events, trauma, other eye surgery, etc. Certainly, examination is key because certainly our patients don't remember everything, but again, it is really important to start with a history. In terms of things that I'm looking for on examination, we want to get a sense of where the lens was supposed to be positioned and where it is positioned. And this can be trickier than we think in certain eyes. So we want to get a sense of what plane it's in. Is it in the capsular bag? Is it in the sulcus? Is it an anterior chamber lens? Is it a scleral fixated lens? We want to also know the type of the IOL, sort of the anatomy of the lens and the properties of the lens. Is it a foldable lens? Is it a rigid single piece lens, etc.? And we want to, again, get a sense of where it is and where it is in time. Where is it right now and has it changed? Is it moving? Is it actively moving? So then this is often a surgical problem, quite frankly, and we'll discuss some of the whys behind that. But this is not necessarily your routine surgery, but it doesn't mean it has to be difficult surgery. I stress to my fellows, surgery is all about the basics. There's nothing individually complex about any given step of any of the surgeries that we are going to show today or can do. It's just a matter of stringing together simple steps that are really based on fundamentals. Certainly, it's important to have a firm sense of anatomy, three-dimensional thinking, and of course, which is something that residents always struggle with these days, is remembering how to suture. I also think it's very important to think about comorbid conditions and recognize that, number one, these are eyes that often have multiple problems, and sometimes there's a synergistic value in treating multiple problems with the same surgical session. If we're not doing all at one go, we want to make sure that today's surgery doesn't compromise tomorrow's staged procedure for the patient's broader needs. And then we want to think about sort of a strategic approach to these eyes. Do we go by ourselves? Do we go with friends? Is this an anterior segment only situation? Do we need posterior segment support, etc.? So with that, I'm going to ask everyone to at least consider the question of UGG syndrome and ask you all to identify, in your opinion, how many findings of uveitis, glaucoma, hyphema, uveitis, glaucoma, hyphema syndrome, how many of these three are required to make the diagnosis of UGG syndrome? Is it 1, 2, or do you need all three? Is this indeed a triad? I would posit that the answer is actually 0. You do not need any of these rather end-stage processes of inflammation, glaucoma, elevated intraocular pressure, or intraocular hemorrhage to really make the diagnosis of a broader problem. It is, UGG is perhaps a fitting name for a tough disease, but does it really accurately reflect what's going on? Colleagues of mine have suggested an alternate definition or an alternate term, and this is not novel. If you look in the literature, UGG syndrome is often mischaracterized as secondary pigmentary dispersion and other things, but we think that this doesn't necessarily address the point and address the pathophysiology. This is implant-related chafing syndrome, in which an implant is causing irritation, rubbing, and resultant problems to the uveal tissue. Therefore, in order to achieve the diagnosis of IRCS, one must have a sign of said tissue IOL or tissue implant interaction, and have certain clinical examination features or imaging features that sort of corroborate this finding. So what are some of these signs? again, think broadly beyond just U, G, and H. This is, again, a bigger process, and we can potentially catch this at varying stages of the progression of the pathology. Is there pigment dispersion in either the anterior or the posterior segment? Increased pigment deposition in the angle. Gonioscopy should be, bread and butter for all of us when we're taking care of eyes of strange pathology. Asymmetry of trabecular meshwork pigmentation between eyes without other explanations such as trauma, inflammation, or asymmetry in surgery specifically. Translumination defects of the iris, especially in an area that we are particularly concerned about from an implant contact perspective. Certainly chronic anterior or posterior uveitis that has not been ruled out in terms of other systemic causes, and evidence of intraocular hemorrhage without any other attributable process such as neovascularization. We do also see patients develop CME, and this can sometimes be the only obvious manifestation of lens-related chafe. So certainly one should have their antenna up in chronic CME patients as well. So looking at a population of patients, these are collected from Ike's group. When I was a fellow, one of my colleagues, Arsham Shabani, when he started practice at Washington University in St. Louis, and we may even grow to include some more patients if we continue to collect data here. But this is sort of a broad population of patients with syndrome, quote unquote, or IRCS. And what we can see here, relevant findings in terms of entry baseline criteria, these are often single piece acrylic lenses, but perhaps that's simply because most IOLs implanted are single piece acrylic lenses in a large extent. But we do see all types of lenses potentially causing issues. Insofar as location, again, the big picture, all locations can cause problems, but the biggest issues showed up in sulcus lens placement as well as bag sulcus placement. So the lens is half in the bag, half in the sulcus. In terms of mechanism of disease, how did this happen? Occasionally, there's documentation of an incorrect IOL placement at the time of surgery, but this is relatively uncommon. Often, a little bit more common, there's documentation of complications of cataract surgery with resultant secondary placement of a lens in a bag or sulcus. We see some underlying patient issues, whether it's pseudoexfoliation or trauma, but very often there is no known cause or etiology. We just often don't have the history. And as a result, these are patients who can kind of linger in the system without a clear diagnosis, sometimes for years. A huge number of these patients have been on chronic topical steroid therapy, and we know that that alone can cause a lot of issues. In terms of manifestations of disease, again, you will see inflammation or hemorrhage or elevated intraocular pressure fairly commonly. Typically, when they make it to a sufficient end stage that they're being referred to a tertiary or quaternary care provider, that doesn't mean this is where the disease has started. Transillumination defects and increased pigmentation in the trabecular meshwork, however, are much more common than the sort of classic traditional findings, and should sort of clue us into hopefully make an earlier diagnosis. Again, pathophysiologically, we are having an implant rubbing against a highly pigmented part of the eye, and that pigment is going to be shed. If we are able to see evidence of that pigment, we perhaps can catch things before it's gone on to cause chronic inflammation or has eroded to traumatize a blood vessel or caused chronic trabecular meshwork injury. Another interesting finding that we noticed was about a third of patients noticed this strange phenomenon of intermittent whiteouts of their vision that otherwise has not been explained. But these are patients who are uncomfortable, they have pain, light sensitivity, and again, often has been going on for years. So management of these patients, in our series, about 3/4 of them required an intraocular lens exchange, and 1/4 required a simple repositioning of the lens. And you can see it's a big list of every possible kind of concoction and combination of lens modification techniques. And again, we'll go through sort of a best of hits of some of these techniques that we can apply in our own surgical practices. These are patients who, again, because of the nature of their disease, often needed adjunctive glaucoma procedures. And this was sort of determined at the discretion of the clinician. And so you'll see some glaucoma procedures also performed at the time of whatever intraocular lens surgery was required. And so overall, these patients did fairly well from a complication standpoint. These are sick eyes by definition coming in, and fortunately with again, appropriate identification of the problem and targeted surgical approaches, a lot of these issues were able to be addressed in a safe manner, but there may still be some persistent issues. In terms of intraocular pressure, I'm a glaucoma guy, so it's always something we're thinking about. People's pressures came down regardless of whether they had glaucoma surgery or not. Of course, the confounder here is people who needed glaucoma surgery got it, and their pressures came down. People who didn't need glaucoma surgery didn't get it, and by addressing the root cause of the pathology, their pressures came down. And the question of need, again, was judged on a patient-to-patient basis based on the severity of their glaucoma, the chronicity of their disease, the magnitude of their intraocular pressure, and of course the number of medications that they were on. Interestingly, sometimes we can resolve a lot of the patient's issues, but sometimes we can't. Often inflammation, the presence and recurrence of vitreous hemorrhage or pigment dispersion can be resolved, as can other issues such as these whiteouts or blurs. But in 3/4 of cases, CME can, 3/4 of cases CME can persist, which means 1/4 of the time we're not successful in eradicating that. 1/4 of the time we're not successful in eradicating light sensitivity, and 1/3 of the time patients continue to have pain and discomfort, despite, again, treating the root cause. So again, there may be some sort of chronic damage to the eye that is at a certain end stage difficult to fully reverse. So in summary, in terms of that classic triad, which is not a triad and was never intended to be a triad, only about 5% of eyes will actually have all three of these findings. So if you take 1 point away from today, throw out this concept that you need chronic inflammation, chronic elevated intraocular pressure, and some sort of intraocular hemorrhage to then call this UGG syndrome and then do something about it. 15% of the time, patients may not have any of these three findings. They can sometimes just have CME, sometimes just intermittent chronic pain that can't be explained otherwise. Delay in diagnosis can result in chronic problems, chronic need for steroids, even when the root cause is addressed. And so what do I tell folks from a technique standpoint? The classic thing, again, bag sulcus position, single piece acrylic lenses. Check that haptic position before you leave the eye, especially in small pupil cases or cases where your capsulotomy may not have been as ideal. It's amazing how many times that's that trailing haptic that sort of just sticks out into the sulcus and never gets pushed in. And it would have been a 2-second maneuver that could save patients quite a bit of quality of life. In terms of clinical findings, increased pigmentation is the go-to finding. If you're going to pick one thing, almost 2/3 of the time, that's the finding. And so use gonioscopy as your friend here to help us make this diagnosis. So that being said, hopefully that point is brought home, that we're able to intervene on these patients early if we catch the problem. Truly this problem happens from, it begins, one should say, immediately after the lens has been placed in the eye in an improper position, theoretically. And so being vigilant about that can allow very prompt and easy correction of the problem. And certainly in some situations, progressive zonular issues can cause lens or capsule mobility and instability. But again, having attention to this can allow earlier intervention or at least counseling of the patient so they know what's going on. So in terms of addressing these lenses, you know, I think it'll be fun to kind of go through a number of ways that I will approach lenses. And really, this is where it gets fun. This is where you get to be a creative surgeon and use what you have, again, to provide safe care. So, you know, something that's highly common, not for Matt, but for the rest of us mortals, is capsule rupture during feko and the requirement for placing a lens in the sulcus. This is a commonly utilized technique, and it is a totally reasonable technique. We know, unfortunately, we don't have at least in the United States, we don't have a true sulcus lens anymore. But a standard three-piece lens, a foldable three-piece lens, can often do very well when placed appropriately in the sulcus. But I would remind us that it may not be as stable as we think. It may not be as ideal as we think. So in a small series that was published now many years ago, there was a commentary on sulcus lens decentration. And there was a sort of a real point of breakage or separation in patients who had optic capture versus not. In eyes who had not had optic capture, lenses just placed in the sulcus and left as is, 14% eyes had decentration, 12%, so 6 out of those 7 eyes actually did develop, you know, what was determined to be UGG syndrome. And again, these eyes were often with longer axial eye lengths. In the cohort of patients in whom optic capture was performed, regardless of axial eye length, there was no decentration and no UGG syndrome. And so this is an easy thing for us to do in the operating room. When we inevitably break bag one in 1,000, 1 in 100 times, hopefully our capsulotomy was fine, and we should use that to stabilize the optic of the lens. It can improve the centration and certainly improves the stability. So this is a patient of mine. He had a 1-year history of chronic inflammation, pain, photophobia. He told me he used to enjoy watching the sunset and couldn't for a year. He just couldn't look. He tried everything, tried lenses, tried everything in the world. He was on chronic steroid therapy and chronic anti-glaucoma medications, and presented to me. We did a UBM, and I think the diagnosis is fairly obvious to us that this is a lens that was in a bag sulcus position with clear contact with the posterior iris. So when approaching these eyes, I like to start by getting the lens in one plane. Whatever plane that is, at least it's one plane, and then we know where to work. So in this situation, we got the lens up into this fully into the anterior plane, and then brought it back into the sulcus. But you can see there's a little bit of vitreous prolapse. What we're trying to do here is achieve optic capture. We thought the capsulotomy was just fine. So this is one of those situations where, you know, an anterior segment surgeon can do a very safe, very limited pars plana vitrectomy just in that area. We don't want to go from an anterior approach here. It may be actually more difficult to achieve our desired goal of pulling that vitreous back. And now that we've done that, we can capture that IOL in what is often a surprisingly firm and tough anterior capsulotomy. Remember, there's been a little bit of fibrosis. This is a thicker tissue compared to our feared posterior capsule. And by capturing it, we see that classic cat's eye appearance, and that lens is completely stable. This was, again, a very quick 30-minute surgery. And on post-op day 1, this patient was 20/20 with you know, complete resolution of symptoms. The next day, he went and saw the sunset, and you know, his world really turned from one end to the other. He was. It's just remarkable how these patients can be passed over and missed for years. One can be even more creative. It's obviously nice when you have a centered posterior capsulotomy, but sometimes you don't. This is a young patient, a 26-year-old who had a traumatic cataract. He has as you can see, about a 13.5 millimeter white to white. This is a big eye. So obviously cataract surgery didn't go great. A 3-piece lens was placed in the sulcus and it was quite decentered as you saw at baseline. And so same idea, we were able to optic capture this lens because the way his residual capsule was sort of hanging out for us, there was a nice, steady and firm shelf for us to use. And so we just use a couple pair of micro instruments here, or forgive me, just a Kugelin and a Sinskey hook, regular old instruments, dial the lens into the sulcus, pop it back, and the lens stayed put. The patient's vision improved because the IOL was now centered, and his chronic pain also resolved. So we get to be creative here. Sometimes sulcus fixation isn't adequate. And again, these are situations typically of longer axial eye lengths, perhaps in eyes where optic capture is not an option. And iris suturing is certainly an option in this situation. I try to avoid iris suturing in eyes that have had vitrectomy and have no residual capsule. I find that there's a lot of iridodenesis and in fact can independently cause UGG. We're managing a patient who's had a hyphema that kind of comes and goes for years that finally has decided to let me work on his iris fixated lens and take care of that. So this is a patient who had an IOL that was placed in the sulcus, but it was placed upside down. So he was in pupillary block. So first thing to do, again, get that lens in a position, in a plane that we can work with, and we flipped it over. Fortunately, the patient has a really, really big eye, so we were able to do that really safely without tickling the endothelium. And then we're going to go ahead and pop it back into the sulcus and see what we can get. Again, I wasn't happy with the capsulotomy size. I thought it might be a little big. And so when I brought the pupil down, we see that the lens didn't really center properly. So this is a situation where a simple iris suturing technique can be applied. We bring the optic up, leave the haptics back in the sulcus, and then this is using 10-O-proline suture to engage the iris tissue around the haptic, and we use a viscoelastic cannula, 27-gauge cannula to externalize the suture. A simple knot is done, and we'll advance a little bit. The same technique is performed on the other side. Importantly, an important pearl that, again, Ike taught me for iris fixated lenses, do the first throw and then pop the lens back into its final position and address the peaking of the pupil now before that knot is locked. So you can kind of pull out that bunched up iris and then go ahead and lock your knots. And then we have a nice round centered pupil and a stable lens in an appropriate spot that's not going to bounce around and cause issues. So again, we all place lenses in the sulcus. We have to do it all the time. Issue number one, make sure it's all in the same plane, either in the bag, either in the sulcus, not both. Try to ensure optic capture whenever possible, but especially in eyes with axial eye length greater than 25, as some studies have suggested. And recognize you can sometimes get away with optic capture in more irregular circumstances. The option also exists to create a primary posterior capsulotomy or round out and the posterior capsule if that's an option that's available to you. And be aware of the possibility of additional forms of IOL stabilization if needed, if you don't have the ability to stabilize that lens. Again, a stitch in time, as they say, and a little bit of prevention may add some value to the patient's life. Again, lenses sometimes are in the bag and still causing problem. And so we can certainly take advantage of techniques to stabilize that. Obviously, a lens exchange is a possibility, but if the patient is happy with their refractive status or a lens exchange may be more difficult for patient-specific factors, we can again get creative with what we have. Often capsular fibrosis can help us. It is it is often tenacious tissue that can provide a firm bed to suture to. And so in cases, this is sort of a unique situation, but in cases of mild subluxation, in patients who are either very old, where you don't want to pass needles in and out of the sclera and or make a large incision, or in patients in whom conjunctival real estate is of issue, very common in my patients, there may be the option of suturing the capsule to the iris. So I'll show you that technique here. This is, again, using a 10-0 Prolene suture. We'll go through the mid-peripheral iris, and then we'll go through the capsular bag here, right through that phimotic capsulotomy edge. And then I dock the needle just to make my life a little easier. And then we'll go back into the eye through that same incision and suture back to the iris. Now, this is a patient who has severe glaucoma. He's 90 years old. He's had a trab that's still functioning amazingly. He has a tube that's still functioning. He has a good pressure, but no room for additional options. So we've gone back through the iris, and we'll just pull the needle out through the peripheral cornea. And we simply tie the capsule to that mid-peripheral iris, and you'll see that IOL slowly come up. We obviously want to move slowly here. But again, in situations where there's still a little bit of zonular support, this is a very simple way to get a stabilized lens without having to do a lot of manipulation on the sclera, the conjunctiva, a lot of anterior segment work. We want to get in and out of this eye as quickly as possible. And so just a little, a simple iris suturing technique here, or intraocular suturing technique, I should say. And that capsulotomy is pulled up and the lens is back into the visual axis. Certainly, in cases of more severe dislocation, that technique is not going to work. And in this situation, yeah, we will often consider fixation to the sclera. Typically, at least 2-point fixation is required just to prevent tilt and rotation. But this can often, again, be resolved and treated through very small incisions without the need for any vitrectomy, because that lens can often sit just on the anterior hyaloid, and we can avoid breaking it or violating it too much if we're careful. Typically, I'll use Gore-Tex suture in this situation, which is off-label, but patients don't seem to mind. And so in this situation, we see a single piece acrylic lens that the patient was happy with that's dislocated. This is a patient with pseudoexfoliation syndrome, so we'll make a scleral groove, enter the eye at the posterior aspect of the groove with a 25 gauge needle, and engage the needle through the haptic optic junction, and pass one arm of a double-ended Gore-Tex suture, double-armed Gore-Tex suture, whose needles have been straightened out. And so the second pass will be performed just on the anterior to the IOL capsule plane. And sometimes there's a little futzing and it can be a little tricky. I know Ike makes it look really easy, but with a little practice, it's not too bad. And we're able to get that, second needle docked, externalized, and then we're able to, now we have two suture ends looping that haptic. And we want to perform the same procedure on the other side, again, to have nice counterbalancing. And we'll use slip knots here, one on each side, to enable us to titrate tension. Now, you can see how much shift we saw with just a mild motion of that suture. One must be very careful with this. Very little manipulation of that suture should be performed in order to prevent further dislocation, as you can see here. And then certainly, you know, again, we can get even more fancy if we don't have sufficient capsular fibrosis, or we do have the ability to open the capsular bag. We can sometimes use fixation elements to provide some support. Again, we can suture to the IOL material in some situations, depending on the material and location. But again, we can use capsular tension segments and sometimes capsular tension rings, although that can be a little bit more difficult to stabilize the lens. So this is a patient with minimal capsular fibrosis and a decentered lens. We'll open up his capsular bag and we'll use an Ahmed capsular tension segment to fixate this capsule complex to the eye. We're using a little bit of a different technique here. Again, I want to show you all sorts of options. This is a technique described by a Brazilian surgeon named Canabrava, using a 5-0 proline suture. One end has been flanged and passed through that central fixation eyelet of the capsular tension segment. And you'll see we'll gently pull, bring that element fundus into the equator of the bag. And then we can simply trim the proline suture and use high temp cautery to melt it into a little flange. And now we have a sutureless fixation of the capsular bag. And we just want to make sure that things are well seated. So this patient had a lot of donesis and decentration. By just fixating things and tightening it up, we were able to stabilize it. So, so those are some of our standard techniques, but you know, nowadays I'm seeing this particular issue quite a bit more, especially in our days when we're doing a lot more scleral fixation and secondary IOLs, particularly things like the Yamane technique. So this was, you know, I don't do Friday clinic anymore. I've passed that joy on to a junior colleague, but for my first several years, I was the guy on Friday, and that's when everything, you know, hits the fan. So this is a patient who had a recurrent hyphema after lens exchange for a dislocated crystal lens. He underwent his lens exchange with a pars plana vitrectomy, and the Yamane flanged haptic technique was performed to place a secondary lens. He showed up post-op day 1 with an eye full of blood, went back to the OR, had a clearing out of all of that hemorrhage, came back on post-op day 1 again, complete hyphema and vitreous hemorrhage. So this happened a couple times. And then the patient was sent to me with a pressure in the 40s on maximum therapy, obviously not doing so well. So this was his UVM, and doesn't look good. So the anterior segment is full of opaque material, that's blood. The IOL, as you can see, is rather anterior relative to the iris. And the couple things to note, again, is that lens position, as well as the orientation of the iris. It is indeed planar. It's not in any sort of reverse pupillary block configuration. We'll see that in a minute. So again, ultrasound shows this lens that's rather anterior, and you know, just sort of assuming the vault of the lens, we can see where a theoretical trajectory for the haptic would go. And sure enough, it's going to go right through the ciliary body, which is not ideal, as you can imagine. So I'll skip through some of this video, but again, this is a patient who is just 1 week out from Yamane technique lens placement. And you can see, you know, the flange is just a little short in terms of position. The technique describes going 2 millimeters posterior to the limbus, and this is 1.5, maybe closer to 2. So not too bad in terms of location, but when we look on endoscopy, we can see where the lens is coming in. That's very anterior, just any more anterior, and that would have entered the anterior chamber. We can see some evidence of chafing of the lens against the posterior iris, all that whitening, the pigment has been denuded. And then we go to the other haptic, again, rather anterior, and you can actually see a little bit of blood right at that site. So, you know, remember, this is just a week out from surgery, and you'll see how difficult it is sometimes to free these haptics up. Again, that's perhaps testament to the technique that this may indeed be a very, very solid means of fixating a lens, but it has to be done properly, obviously. And so we'll see here that we're going to start to work on this haptic. We can see that little flange there. And what I tried to do was kind of a push-pull technique where we pushed the IOL from the inside and kind of rotated it out. And then we'll use a pulling technique where we'll just grab it with a Colibri tooth forceps here and then finally mobilize this haptic. We'll trim off that little flange, as little trimming as possible, so we have the maximum amount of haptic left to work with. And then we essentially redock the lens. So we'll dial this lens back into the anterior, the haptic, I should say, back into the anterior chamber. We'll do a repeat needle passage, but this time we're going to make sure we go a little further back, and we're going to ensure that we're perpendicular to the plane of the sclera. This is the key point here, perpendicular to the sclera, not working in the iris plane. And so by doing that, redocking the needle, as the traditional technique is been demonstrated, we're able to again reorient that lens and just sort of walk it back one haptic at a time. Now I will note that this lens specifically makes this possible. This is the formerly EC3 PAL, now the CT Lucia 602 IOL from Zeiss, which has these really tough haptics made out of PVDF material. So this stuff is, while it's not unbreakable, it's pretty hardy and can tolerate all of these manipulations. If this was an MA60 AC or some of our other standard three-piece lenses with PMMA haptics, the haptics would have bent, broken, or disinserted from the optic by now. And this would be a situation where the lens would likely need to just come out and another one placed. So again, we'll do the same technique here, nothing too exciting. And then we're gonna go back in with ultrasound. We can see how much more posterior the lens is positioned. We did a little bit of endocyclophotocoagulation here just to shrink some of the ciliary processes in the area, do a little bit of intraocular cautery just in case there was still a little bit of mobility. But sure enough, this lens was way further back, and there was no major hemorrhage on post-op day 1 anymore. So in terms of what we're talking about here, we want to think about our anatomy in 3 dimensions. We want to not measure back from the limbus, but measure back from the scleral spur or the surgical limbus. We want to measure posteriorly at the appropriate amount. And instead of entering in the iris plane, as anterior segment surgeons like to do when working in the anterior chamber, we want to enter perpendicular to the sclera. Otherwise, we're going to end up more anterior relative to where we thought, because the eye wall actually has thickness. So we're gonna end up in the ciliary body or the iris root potentially. Again, think about the scleral spur. This is an anatomy location that we can very clearly visualize surgically. And this is a true correlate to intraocular anatomy. The limbus, the clinical limbus is highly variable, but the surgical limbus or the scleral spur are tightly correlated. And we can use that as a benchmark to measure back 1 millimeters, 2 millimeters, etc. Now, with these scleral fixated lenses, do not forget reverse pupillary block. I've seen dozens and dozens of patients who've been referred from the retina service after a lens has been placed with intermittent chronic pain. And sometimes you'll never catch them as beautifully as this patient was caught in that classic reverse iris configuration. So again, this is a patient with high pressure, pigment dispersion, translamination defects that nicely stamp out the 3-piece lens. And in more advanced situations, I've seen, again, the optic actually prolapsing through and getting caught in the pupil just from this force. So simply placing an iridotomy, and this was, again, like an instant gratification kind of situation, can solve this problem, certainly. And now whenever I put any sort of scleral fixated lens, Yamane technique or otherwise, I will always make an iridotomy just to cover myself. In addition to placing the lens in an appropriate posterior position, we want to stabilize the iris as much as possible. So in terms of general principles here, 3D anatomy and knowing our surgical landmarks using the scleral spur, enter perpendicular to the sclera. It's contrary to what we often do as anterior segment surgeons, but it's necessary when working in the posterior chamber and posterior segment. And again, I do this on all cases, place an iridotomy to prevent reverse pupillary block. And in fact, this can also be seen even in uncomplicated sulcus IOL placement. So have that on the radar. I don't prophylactically do PIs in those situations, but it should certainly be considered. And certainly if the lens is really dislocated, you're not going to try to reposition it. This patient who has severe pseudoexfoliation syndrome, a lens that's way far away, and you're going to see as I hoist it over how phimotic that capsule is. This lens is coming out. We're going to take this lens out. We'll put an anterior chamber lens in, and we're not going to think twice about that. And this patient's going to do just fine. Remember, ACIOLs are fine if it's well placed. I try to avoid them in younger patients or patients in whom corneal work is going to be done, endothelial keratoplasty, but often an ACIOL is a totally appropriate maneuver. Just make sure it's measured properly. Take the time, measure the white to white in multiple axes, and choose the best fit based on that. And never undersize the lens. So try to find that sweet spot, but never undersize, because then the lens can move and cause a lot of issues. In terms of adjunctive procedures, again, in my practice, a lot of these folks have elevated intraocular pressures. And so again, we talked about this earlier. This is a clinical decision in terms of the decision to do adjunctive glaucoma surgery. My rule of thumb, if they're on medications, I'll do something. If they have a huge medication burden and or severe optic neuropathy, then we're gonna kick it up a notch, perhaps do a tube shunt or something like that. But this is often a trabecular meshwork disease. So some of our standard Schlemm's canal, microinvasive glaucoma techniques, goniotomies, stenting, viscocanelostomy, et cetera, can be particularly applicable in these eyes. So again, to bring it home, remember our basics, our three-dimensional anatomy, using both hands, suturing, just sort of basic stuff strung together can really make complex stuff and complex challenges like these UG patient scenarios really manageable. Certainly want to have the right surgical tools for the job and be prepared. Think about the big picture, use what the eye gives you, and again, be open to that possibility that a lens implant is causing these low-grade chronic symptoms that we can address if we hit at the right time. Again, thank you all so much for your time. I hope we have a little bit of time for questions and conversation. I know I'm on a panel with some real heavyweights in our world. So I look forward to talking with all of you. Thank you again.
Well, that was just a fantastic talk, Manjul. So thank you for sharing that with us. I thought it was just really, really fascinating. If members in the audience have questions, we are happy to take them, but I will open it up to the panel for any thoughts first.
I have some questions, Manjul. If we go back to the UG syndrome, I'll tell you where I'm coming from and see what you think. So the first patient that made me worried about sulcus IOLs was a lady who came to me about 20 years ago and had had congenital cataract surgery at Sick Kids many years before. But now that she was a lawyer, she found that she couldn't wear her contacts all day and she wanted intraocular lenses. So like everyone else was doing around 2000, I went and I put in sulcus IOLs and she was fine. Mm-hmm. 3 or 4 years later, she came back and I saw that her pressure, instead of being like 13, was now 16. So I said, well, come back in 6 months. And then it was 17 and 18. Then I said, well, 1 second, this is not good. Looked at her angle, saw pigment, took her back to the OR, although she had no complaints, captured her IOLs, and she was fine. Yep. Next one I had was a recent one who came in about a year ago, and this lady came in, not very old, also had cataracts quite young. She was now in her 50s. 2 different surgeons had done her cataract surgery. Her left eye had the lens in the bag, and the right eye had the lens in the sulcus. And it looked like she had too big a rhexis to capture the lens, and I thought the lens was sitting a little bit below the horizontal. So I sat her in the office, gave her tons of eye drops, a dilator, and I could see that behind the inferior part of the lens, there was a little ledge where perhaps I could capture that IOL behind it. Fortunately, she was -0.5. Took her back to the OR. She wasn't eager to go there because she had really not a complaint, except she said that sometimes her vision wasn't as good in her right eye. Mm-hmm. And like the graying out syndrome and stuff, it wasn't quite right. So I went and I put that lens in a 3-second operation, just tilted it back to catch it behind that ledge of capsule. She's probably one of my happiest patients. She came back and in a week she said, you know, all my symptoms gone away. I see equally well in both eyes and everything is fine. And of course, she had more pigment in that angle than the other one. So what's the question? So the question is, should we ever accept sulcus IOLs? Everyone in whom we put a sulcus lens in, everyone we do cataract surgery, will get a Summering's ring. That Summering's ring is going to keep pushing the lens further and further anterior. And over time, you know, we do some young patients, just about all of them, as far as I can tell, will end up getting an iris chafing syndrome. So should we, in your mind, ever accept a sulcus IOL?
Yeah, I think that's a really really good point. And Steve, I've seen countless patients who presented like this. And in fact, Ike's gonna love this, but you can sometimes reposition. I've repositioned a bunch of those right at the slit lamp, depending on what their anterior or posterior capsulotomy looks like. You can just pop a 30 gauge needle in and just tease that lens back, and then patients really love you because you fixed it in 10 minutes at work. So, you know, I think you make a really good point. I think it's, given the alternatives, especially in the right patient, yes, certainly in a young patient, I would really worry about a lens in the sulcus for exactly that reason. And we've certainly here removed well-placed sulcus lenses in patients who had them placed years ago and instead opted for some sort of a scleral fixation type technique. In an older patient, perhaps you'll get away with it because even as that Summering's ring is growing, it may not catch up to them. So I think it's should be certainly considered on a patient by patient basis, but I don't know that I wouldn't say never, but it's probably not as easy to pull the trigger on sulcus lenses as we usually think.
So Stephen Manjul, what happens if you have a case with a big capsulorhexis and the bag breaks? 50-year-old. Are you going to put in a sulcus or are you going to do something else?
So here was the follow-up question, which Sharif was maybe coached to give to me. I've decided since that I have reduced my capsulorhexis size to 4.6 to 4.7 millimeters. And the reason is if you do the math and you equate the perimeter of the capsulorhexis with twice the diameter of the lens, anything more than about 4.8 will not capture a lens well if you have a problem in surgery. So I stopped doing large capsulorhexis altogether, despite the fact that there are endless articles saying that the surgery is easier with a bigger rhexis. What are your thoughts on that, Manjul?
Yeah, I think that's absolutely reasonable. I definitely slightly undersize my rhexis in patients in whom I'm particularly concerned that we're going to have to go sulcus. The classic example there is a posterior polar cataract where I'm definitely going to undersize. Even a toric lens, I'll often undersize a touch just in case something happens. I don't want to put a lens in the sulcus. I can do a sort of a reverse capture, put the haptics behind in the capsular plane and pop the optic forward. So in those unique situations, I certainly do capture. Again, in most situations, I don't because 99.5 times out of 100, we don't run into an issue. But it's not unreasonable to have and again, 4.6 is not so undersized that it's going to really make work more difficult. In these situations where things happen later down the road, there is a little bit of phimosis of that capsule. So what may have started as a 5.5 becomes a totally reasonable size to capture and secondarily. So, you know, at least that's working for us in some situations. Certainly if it's very huge, it's not going to work. And to address that question, yeah, big capsulorhexis in a big eye with a broken capsule in a young patient, geez, this may be someone who, again, they're going to live long enough to have problems from this lens, and we don't have a good, really, really large haptic sulcus lens. This may be someone in whom we go primary scleral fixation here, either a Yamane technique or some other form of scleral fixation. And it's totally not unreasonable to do a good anterior vitrectomy and call it a day and come back when you have the lens you want to fixate to the eye. You may not always have the lens that you need in the power that you need for a safe scleral fixation technique.
Yeah. But the reason I've opted to small rexes is, you know, the patient that's usually the problem is the one you weren't planning to have a problem in.
Yeah, of course.
Because the posterior, above polar ones and the other ones that are, you know, hopefully or might be awful, you plan ahead and don't have a problem. It's the person who you thought would be perfectly fine that ends up being a problem. The guy who wants a clear lens extraction because he's +4 and loves to play golf, right? And so I found that making a smaller rexus and just polishing the underside of the capsulotomy prevents phimosis later, and it's much easier. If something happens, you just capture the lens.
Yeah,
Makes life much easier. So I have one more question, but anyone else want to go first?
So I have a question for Mendel.
Thanks a
Oh,
lot
go
for
ahead.
that discussion.
Go ahead, Ike.
Oh, go ahead. Go ahead.
No, for sure, man. You first.
Just a quick question. This is a common question I hear from my colleagues in that we do find, of course, that one-piece lenses are, of course, a risk for UGG syndrome. What do you do, though, if you have a patient that has a one-piece in the sulcus and they don't have any problems? Do you address it, or do you just wait till there's a problem?
So this is where you kind of, absolutely. And I do have a couple patients who are kind of chugging along without an issue. They just are told, the first time I meet them, I say, this isn't the right thing for you. The lens is in the wrong position. Often these are 20/20 eyes and they haven't had an issue yet. Sometimes you will see TIDs and a little bit of extra pigment, but they're not noticing it. And I tell them, look, I don't know if and when this is going to cause a problem, but if it does, it can cause permanent issues. And so, you know, surgery now can be relatively easy. Surgery later can be a little harder. And you know, sort of let the patient make up their mind. Try to just give them the best information they can. But my bias certainly is to recommend surgery because, again, catching it in this early asymptomatic state is essentially curative. But you know, it's a tough sell for a 20/20 happy patient to go in and have lens surgery when they're not noticing a problem. But as glaucoma specialists, that's what we do all the time. We operate on people who don't really feel or know they have a problem, and they'll never know what we did for them theoretically. So again, I typically leave it up to the patient on some level.
You know, I agree, Manjul. Let me tell you what I do and then see what Ike does. I tell those patients, well, you know, it's not quite right the way your eye is, and you're having no symptoms, but how long do you plan to live? If you plan to live a long time, you should fix it because it will most likely cause you trouble in whatever number of years. And they all agree. And some of my happiest patients are patients who came in and it may have been difficult to dissect open the capsular bag and put that one-piece lens back into the bag. And I put them in the bag and they're fine. And then they're quite happy afterwards. Exactly. But if you don't do that, they will come back miserable one day.
Absolutely.
What do you do?
Yeah.
Well, hey, listen, I mean, I think we're highlighting some of the problem cases. The reality is we don't know the denominator.
Right.
I mean, there are thousands and thousands of sulcus lenses put in over the last 50 years, and the vast majority of them have been fine. So I don't want to raise the alarm bells and ask people to refer all these patients to have these lenses addressed. I do think that proper follow-up is appropriate. Typically, UGG syndrome, I mean, unless they get an acute bleed, does take some time off, and then it can be chronic, and you can address it then. So I'm a bit more conservative, to be honest, especially as someone who's, you know, perfectly 20/20. These surgeries are not uncomplicated. Sometimes they have vitreous that comes forward because they, of course, had a problem with their capsule. The secondary IO you put in could cause a problem, whatever you do with it. So it's not a benign surgery. Again, this is someone who's taken out over 1,000 lenses in my career, but I still exert caution. And so for me, I'm a bit more conservative. I like to see some evidence, whether it's dysphotopsia, whether it's impending dislocation, or whether it's evidence of UGG syndrome. I would address it at that point. And you usually have time. That's kind of my own bias, though. Maybe I'm getting older.
No, and you're right. There are a handful of patients who, again, you look, I'm like, that lens looks kind of close to the iris. We do a UBM, they have their lens card, it's a single piece, they don't dilate well, it's in the sulcus, but yeah, there's nothing else wrong with the eye. You can't see any asymmetry of pigment, you can't see any, certainly patients are asymptomatic. Yeah, maybe we're gonna get away with it there. But once they start to show some clinical signs, I'll, you know, maybe lean them in the direction, but at the end of the day, it's their call. And I've had patients go both ways for sure.
The only thing I'll mention is that, and I think this is one of my biggest pros I'll mention, is that any patient that comes in with uveitis or pigment dispersion or particularly unilateral IOP, it's an IOL problem until ruled otherwise. Too often patients are treated for uveitis, and in fact, it's an IOL problem. So I recommend, even if it's in the bag, and in fact, your colleagues at University of Michigan published a series of patients within the bag, UGG syndromes, due to different reasons, whether it was an IOL that was perhaps in a large rhexis or a large Sommering's-ring or zonular weakness. But whenever there's a uveitis situation like that and the patient is pseudophakic, the first thing to rule out is a pseudophakic related uveitis, as you mentioned.
Yeah, absolutely. Yeah, I've definitely had just a bag where one side of the zonular apparatus was a little weak. So it's just sort of seesawing and banging into the ciliary body and iris. And those are easy fixes. I mean, relatively easy fixes, but sometimes the diagnosis is harder than the fix sometimes. But yeah, be attuned to that possibility.
So Manjul, I have a question for you. What do you think it causes that gray out or white out symptom that patients experience? I have a patient who I met who has a 3-piece lens in bag sulcus position and describes a very clear and repeatable history of this gray out when she's on a plane that's landing. Huh. And I don't really know how to explain that. So I don't know if you or anyone else has thoughts on that.
Yeah, we've thought about it. I don't have a clear explanation either, unless there's, again, the plane landing, that's interesting. I definitely don't have an explanation there. Is this sort of something akin to a pigment storm in a pigment dispersion syndrome type patient? I don't think it's hemorrhage, because you would see that layering and it's sort of a different character, but I wonder if it's sort of a destabilization or an acute shedding of pigment. But it is rather characteristic and rather strange. So no, we haven't. In fact, I think Arsham had actually asked one of his neuro-ophthalmology colleagues to kind of weigh in on that, and we still didn't have like a clear sort of mechanism of what's going on there. So yeah, I don't know.
Steve, I think you had another, or John has a question. Yep.
Just a quick one. Actually, that was my question as well about the whiteouts, which we don't seem to know if fascinating, but it's a characteristic symptom. But thank you very much for the excellent talk. Why do you think that suturing the lens to the iris doesn't still give chafing? You've now taken a lens and made it even more anterior, rubbing right up against the iris. Is it that the lens and the iris are too stable, they don't move against each other?
Yeah, so in that specific context, you have a relatively stable iris and a weak zonular apparatus, so the one is coming into contact with the other. By just fixing the two together, they either move in concert or they just don't move much at all. And again, this is sort of a fringe technique. I don't do this very often. You can count on one hand the number of times, only in those specific patients in whom you really don't want to do anything that maybe a little bit more, more of a comprehensive solution for any number of reasons. But yeah, it's certainly a concern. But if the IOL is completely encased in the bag, so it's not like you have a errant haptic rubbing or something, then perhaps by stabilizing the two structures, we're going to mitigate some of that amplitude of motion.
I think Steve had another question that he held off on.
Yes, I have another question. I have only one comment about your implant-related chafing syndrome, catch-all term for this, which I agree with, but I think it's broader than that, because I think we have to include pigment dispersion syndrome and pseudoexfoliation as really similar problems. When you get dispersion of something that blocks the angle that causes them problems. And I always do things that nobody else does, and I kind of am quiet about it for a while until I see one paper, then write another couple. And for about 20 years, I've been taking people who have bad family histories of pseudoexfoliation and pigment dispersion and doing cataract surgery relatively young. And they tend not to get problems because they stop getting pigment or pseudoexfoliation material in their angle. And I wonder what you thought about that and how maybe we should broaden the concept to include sort of natural iris chafing syndromes.
It's an interesting idea. I mean, again, I think there may be additional, especially in pseudoexfoliation, there may be additional factors at play in terms of the composition of what's going on beyond just the true debris clogging the drain, as it were. And I think, yeah, there is absolutely an argument there, especially, for example, in pigmentary glaucoma, for placing iridotomies in certain patients, just to, again, sort of do the same thing, get the iris away from the thing that it's rubbing against. But the evidence for that specific idea, for iridotomy in pigmentary glaucoma, which is sort of doing the same thing, isn't great. And so I wonder, are we over-treating some people? Perhaps. It's a little bit of a tougher call, I would say, because while I think the lens is certainly part of the pathophysiology, it's not the whole story. And depending on when you catch these eyes, often by the time they have lens opacity in a pigment dispersion patient, they have enough growth of their lens that they are now in pupillary block and they're no longer shedding pigment anyway. So unless you catch them and do a lensectomy at 35 or 40, we may not necessarily be fixing anything in those eyes. Pseudoexfoliation is an interesting option, but we know that exfoliative material is not just released from that center capsulotomy, but from all of that tissue. So we may not necessarily be stopping the process, and we'll see, that exfoliation continue to occur. So I think there's something to be said there for a grouping of secondary open angle glaucoma, certainly. And I definitely try to think about that when I'm thinking about glaucoma surgery, because if this is trabecular meshwork disease, these eyes can do remarkably well with just a very simple goniotomy, sometimes with just a 25 gauge hypo, you can fix a lot of their issues with very little effort.
Matt Schlenker had a pretty interesting comment here. I don't know if he's put in the chat, but Matt, you want to talk about the amputation? Sounds pretty interesting.
Great point.
Hey, man, Joel, nice to see you. Long time no see. Great talk.
Yeah. Thank you, Matt. Good seeing you, man.
Yeah, I mean, I think I had one on Tuesday where I was going to do this, but as Steve said, often the bag opens up. Just use your magic OVD. And we had one on Tuesday where we opened up the bag and redeposited the haptic. I had another one who had the $1 million workup for neurovascular events because every time he bent over, he saw white. Yeah. And I said, was it black or was it white? He's like, no, it was white. And sure enough, he had the classic, it's been called God's finger, the TID that you can see as a from the haptic. Yeah. And his was just, he had a very adherent bag. So I just simply amputated that haptic. Yeah. And I also had put in the chat, and I think Manjul highlighted this really nice. There's two possible issues from UGG. It's a malposition and or a mobility. And unfortunately, sometimes it's both. And that's why you can get it in the bag UGG as well, because it can be a mobility issue. In this particular eye, it was very clear that there was not a mobility issue. He didn't have a lot of cylinder, which can happen when you have a bag sulcus position. And he was elderly, and we just wanted to get this thing out. And he was so happy to get rid of his whiteouts. And then, like Manjul said, another reason not to go all out and try to preserve as much of the bag as possible is for glaucoma surgeons, we hate vitreous coming to our surgeries. But more and more, I am doing what Manjul said, which is trabecular bypass approaches in these settings, assuming that we have a trabecular bypass or a trabecular meshwork problem, i.e. pigment, inflammation, steroid response that has led to chronic changes to our TM. And this is nice because I don't have to worry about trying to yag vitreous out of my tubes and ostomies, but it's also just a smaller surgery when you're already going in, by definition in UGG, these patients have already had endothelial insults to their eye, at least one from their original cataract surgery. And many of them have had more than that. So I completely agree with what Manjul said. Again, I don't know about micro stenting for the TM bypass because they've already had hardware issues in their eye, but I like more the incisional or excisional trabecular bypass techniques.
Yeah, great point. I had a case just a couple of weeks ago where, you know, a large capsulorhexis, the trailing haptic was left in the sulcus, and my plan again was exactly that, to go in and amputate. And easy, fortunately, bag opened up nicely. I was just able to spin the lens back in, and we were good to go. And it's patients, I mean, like refractively actually a little better, because she had a little bit of a myopic refraction and a little bit of SIL that we just corrected by dialing the lens back. And you know, very safe procedure. So, but absolutely, cutting that haptic off is often a really easy and elegant solution.
Manjul, you know, sometimes, you know, these are some really old patients, as we've said. And how do you feel about the use of cycloplegic like atropine or myotic like pilocarpine, which can immobilize the pupil? Sometimes that, you know, I mean, patients don't want to go to surgery, or maybe it's COVID or whatever else is going on. How do you feel about pharmacological treatment if it's tolerated?
Yeah, I think great comment, Ike. I've definitely used that, and it can surprisingly get us by for a long time. I'm managing a patient right now. I think I mentioned him earlier, who has a iris fixated lens that moves, and intermittently he'll have a hyphema. But and the last time he had a hyphema, he's on Coumadin and his INR was through the roof, and he had a coughing episode. And then ever since then, I just put him on atropine, and he made it for like 4 years without another rebleed. And now, of course, he's now no longer tolerant of atropine, and he has a 5 millimeter hyphema. We're going to take him to the OR in a couple of days. So yeah, I've definitely seen some success there. May not fix everything, but if they tolerate it, especially, I think cycloplegia more than pylo, just it lasts a little longer. It provides a little bit more stability. Perhaps better tolerated in many situations, but yeah, great point.
I just want to make a small comment on the hyphema issue that I've seen a few times. I think Manjul showed a case that had recurrent bleeds. And this is part because I do a fair number of GAT, so maybe I'm getting numb to hyphemas. But if you have a little hyphema or even a lot of hyphema and you have a high eye pressure, in some ways that's good. Because I've seen a few times now, people get a little bit spooked with a little blood. What do? They clean it out and they lower the pressure. And then what happens on post-op day 1? They're bleeding again. And then they go clean it out and then they go bleed again. Right. So unfortunately, you know, ask them about blood thinners, and you sometimes have to ride it out. And yes, it sucks because the patient can't see and the pressure is a little high. There is a risk of endothelial blood staining, but you have to tamponade a little bit. You can't get, for some of them, you can't get too excited, or I think it's better to have a chronic bleed and a clot than recurrent bleeds over and over again, because you keep on decompressing the eye.
Yeah, great point. Whenever we are doing a washout, if it is indeed time for that, typically when we're done and everything's clear, I'll purposely decompress the eye and see if I can find a bleeder. And then depending on the magnitude of it and the location, sometimes we'll do a little cautery or whatever the case may be. But yeah, that's a great point. Sometimes just let it ride for a little bit, recognizing, you know, that you're going to go in and fix this, you know, imminently. You know?
Okay. Yeah, and I love your use of the endoscope, both to visualize and then also to cauterize. I think that's a fantastic tool and trick. You had some great images there. The resolution is not always so good, so I'm impressed.
And in these eyes, I'll often use the 23 gauge endoscope and go pars plana if I'm going in with a retina surgeon. So it's even worse a view, but I've certainly made diagnoses based on the endoscopic examination as well. So it's a fantastic resource to have available.
Okay, we're coming to the end of the time. So does anybody have one last question? No? Okay, time's up. All right, well then, Manjul, I really want to thank you. Like all excellent lectures, you solved quite a few problems for us. You gave us some good things to think about, and you left us a lot of questions for our young colleagues to work on for the next 5 or 10 or 15 years.
Awesome.
To solve some problems. So thank you very much. It's been really wonderful. The day I met you was a fantastic day, and Ike was really lucky to have you as a fellow, and we really enjoyed all you've contributed to Toronto, Ontario, and our society. So thank you very much for doing this for us. And I'd like to ask Babak to talk a bit about the TOS future plans and what's happening next.
Thank you so much.
Is Babak still here? Well, maybe he won't.
Yeah, there you go. Yeah, thanks a
Okay.
lot. Yeah, no, I muted myself. Thanks a lot, Manjul, for that excellent talk, and thanks to the panelists for that lively discussion afterwards. It always makes it more interesting when you have a discussion like that. And yeah, in terms of what's going on, really, like I think in terms of I mentioned in the fall, we've had to reevaluate or maybe put on hold the plans for the fall gala. We usually have a fall gala every year. Usually it's in September, October, but we've had to put a hold on that. We may push it back to November. We're just still in talks in terms of figuring out the logistics of that. We'll keep you posted. Like I said, if you want to check back on the TOS website, we'll update you. We'll also send an email blast to all the TOS members once we have further information. But yeah, this was an excellent talk. Thanks to everybody for participating. And yeah, we'll hopefully see each other, hopefully in person in the fall.
Okay, and thanks to everyone from the university for all the work you did and help us get this going. It's wonderful to have these meetings annually, and hopefully we'll continue. And thanks again, Manjul. I'll email you again, see how things are going. It was really a terrific talk. I really enjoyed it.
Thanks so much. Thanks for the invitation and the fun conversation and all that the Toronto community has done for me. I really appreciate it. And it's great to connect again.
All right.
Manjul, your talk was awesome. So thank you for sharing that. And I have put in a link in the chat box for all of our audience members to complete an eval, which is required for CME. But Manjul, thank you again. It was a fascinating whirlwind talk.
Thanks, Amandeep. Good seeing you.
Okay, thanks everybody.
Good night, everyone.
Good night.
Okay, good night all.
Good night.